Okay, so we're here for our last video, and I'm going to try and make this as brief as possible. I'm even going to set a timer, but it is hard. This is the bulk of your content, and it is about the actual provision of nursing care postpartum, and this is where your role fits in. What do new parents need from nurses? Well, when you ask them, they'll say that they want or need respect for their privacy. And you may think, duh, but there are all kinds of interruptions when you're a patient in the hospital. You don't have control over all of them. So making sure that you knock, making sure that visitors know to knock, putting a do not disturb sign on the door if they want that rest period, um, that's important to patients. Also, respect their modesty by closing a curtain, by shutting the door when you're about to do your assessment, and being responsive to their personal needs. If they call, they want you to come, or at least say, if you get on the call bell and say, I can't get in there right now, I'm with a patient, but I'll be with you as soon as I want. Or someone else can maybe meet those needs, but that's what they want. What they mostly want is information. I'm going to make this pretty accessible for you because a postpartum family, a new parent, is a lot like an undergraduate nursing student. They have this big, big job that they're not sure if they can do, and they want to do it right. And they want the information, and they want it in a way that makes it easy to use it. They have all these new skills to learn. And soon enough, sooner than they're ready, they're going to be out without your support, and they're going to need help. So, with that having been said, mothers and fathers verbalized some different needs and some things that were the same. The moms thought that the nurses prioritized the newborn care a little bit too much to the exclusion of self care. And they wanted that information and help with healing along with the newborn care information. Fathers wanted to be included in all this teaching. They verbalized that everyone addressed mom and nobody talked to them, and they felt like they were inadequate to the role of parenting. They were expected to help, but nobody taught them how. So you want to get dad in there. This study was all on heterosexual couples, but it really just applies to whoever the main support person is going to be. And both parents verbalized that they wanted to feel competent as parents, especially with breastfeeding, which they felt was sort of a foreign skill. They were sort of a little more familiar with diapering or bathing, but breastfeeding seemed really complicated to them, and they felt that they either didn't get enough information or support, or that the information they got was inconsistent, which leads us to our last point. Make sure that you are giving them information that's consistent with what your hospital discharge information is teaching them. Okay, so what are our priorities for care in the postpartum period? Of course, assessment, assessment, assessment. You're always looking for complications, and then you want to reduce the risk of those complications. We're managing pain, we're promoting rest, and we are teaching. And then we make them teach it back. Okay, so since teaching is an important job in postpartum, you may have noticed when you go in with nurses or with your clinical instructor that we're teaching every time we walk into a room. If we're looking at an incision, we're teaching incisional care. If we're getting a patient out of bed, we're talking to them about why ambulation is important. So teaching is your biggest job on postpartum units. Make sure that your information is correct and up to date, and hopefully it's consistent with what all the other nurses are telling them. You don't have control over what other nurses say, but if you know that your information is correct and up to date, they'll be more confident in your care. It's a show and tell kind of thing with the emphasis on show. It would be similar if you went in and gave a lecture on baby care. If I to a situation in which I maybe tried to teach you how to do a Foley, but never opened a kit. So you need to show while you're telling. And then you use the teach back method. So an example of this could be you're bringing a baby back from circumcision, you open up the diaper, you show them how to put the gauze on the Vaseline by doing it in front of them. And you're talking them through it. And then you say, the next time you change a diaper, I want you to call me into the room. I would like to see you do it. Give positive and constructive feedback. When you see them doing something right, tell them, yep, that's how you do it. Like if they latch the baby and they're doing it themselves, give them that positive feedback. If there's a problem, if, say, the baby's positioned a little awkwardly, maybe they're not tummy to tummy, you're going to give them that constructive, show them how to do it. And then when they do it right, give them positive feedback again. A word about the printed materials and the videos. I have heard nurses say, well, it's in the folder, so I didn't worry about it too much. I don't have to cover that. Well, that's very similar to an instructor telling you it's in the book. Um, you know, it's more helpful for them to get that demonstration and that teach back. And then you reinforce it with the printed materials. If they watch a video, that's great, but you still need to see them do it. They still need to demonstrate that they're able to do it when they're home alone without you. And then lastly, you want to provide a phone number so that they can call with a question. Let's say they change the diaper and something happens with the circumcision. That yellow crusty stuff is on the tip of the penis and they forgot what you said and they're calling to make sure it's okay. Give them a phone number to call. And now we're going to move on to all of the risk diagnoses. Our first risk is risk for infection. And there are many sources of infection in the postpartum period. We have mastitis. You have plugged ducts, which is when the milk gets like stuck and forms a little crystal. Milk is full of sugar. It feeds bacteria. If you have cracked nipples, you now have a portal for infection. So that's one source of infection. Endometritis, where that placenta detached from the uterine wall, the uterine lining can get infected. Urinary tract infections can happen as a result of catheterizations or trauma to the bladder or improper hygiene. And then we have wound infections for our C-section patients. So preventing them is really important. And a lot of it will deal with teaching. Hand hygiene, both for staff that comes into the room and visitors. We should be telling parents, don't let anybody in the room unless they've given themselves the hand hygiene. Show them where the hand dispenser is. Mom should be using hand hygiene before and after pericare, before she touches her incision, before she breastfeeds, to prevent like transfer of organisms to those places that are vulnerable. Always front to back for perineal care. Change the pads every time she pees, which should be every 2 to 3 hours. Give her extra pads to take home so that if expense is an issue, that's taken care of. But, you really need to be careful there. Use of a peri bottle is also important with perineal infections. She shouldn't be rubbing with toilet paper. She should be sort of rinsing and patting dry. In terms of UTIs, fully out ASAP. Voiding frequently. Keep that bladder empty. Don't have any bladder stasis. Shower daily, whether it's a C-section or vaginal. Prioritize that shower over your dishes, over your laundry, over your housework. It's more important to do that and make sure she's using a clean towel. Nothing in the vagina for 6 weeks. That means no tampons for the lochia, no intercourse, no douching. There is no need to put anything in the vagina for 6 weeks. If she's going to break that rule for sex with her husband or partner, condoms are advisable. Most women do not want to have relations that early. They're just too sore, but you never know. Some do. As far as incisional care, get in the shower every day. Let the warm soapy water run down the incision and then pat dry with a clean towel. Check the incision every day and look for redness, edema, all of that stuff. And we'll talk about that with post-op complications as well. We're going to address the cracked nipples to prevent any kind of mastitis, improve the latch and position. That's the first line of defense against cracked nipples. And then we can use those gel discs, and I'll talk about them when we address pain. But you want to heal cracked nipples because that's one source of infection. And tell mom to be consistent with nursing. If she's going to nurse a lot one day, she should be nursing the next day or pumping or expressing it out, because milk supply works on supply and demand. If she stimulates a large volume of milk to come in and then doesn't express it, that milk stays in the ducts. It can plug the ducts, and that's a source for infection. Next, nursing diagnosis is going to be risk for complications related to bleeding. And we talked a little bit about it in postpartum assessment. We'll talk about it again in postpartum at risk. But some of the interventions we do to prevent complications from bleeding, right after delivery, there's usually standing orders for oxytocin. Now, if your mom has IV access, that's the preferred route. If she does not, we can give it intramuscularly, but it helps the uterus to contract, which will put pressure on those bleeding vessels and prevent uterine atony and subsequent hemorrhage. So that's one of our first things. You want to teach mom to keep the bladder empty, and we want to make sure that she's voiding, because a full bladder will displace the uterus and cause that uterine atony again. We're monitoring the fundus of the uterus for its height, its consistency. If it's boggy, we're doing massage. If we have to express clots with that fundal massage, we do it. And that will prevent that excessive bleeding and catch it before it's a big issue. We monitor the CBC so that if she did lose some hemoglobin, they all lose some, but if she did lose it and it's at the point where she's now anemic, we can address that either with supplemental iron, which we can give PO in most cases, but if she's low enough, we might give it IV as Venifer. That's iron sucrose. And if it's really low, if it's below 7 and she's symptomatic, we usually want to transfuse with packed red cells. We're going to do a lot of patient teaching. After the first couple hours postpartum, mom's, sort of getting assessed a little less frequently. So we want her to know how lochia should progress, that it should get lighter in flow and in color as it progresses. If it's been bright red and then it turns to pinkish brown, it shouldn't go back to bright red. She should not be soaking a pad in less than an hour. She should not have a clot bigger than an egg. If she does that while she's in the hospital, she needs to get in the call light. If she does it at home, she needs to call her provider. And she needs to keep her bladder empty. Next nursing diagnosis is risk for fall. So we have a significant number of women who get epidurals, and those effects can linger for several hours after delivery in some patients. It takes a little while to wear off. So this patient is a falls risk. Do not let the patient get out of bed without you. Before you get her out of bed, assess her motor strength and sensory function in her lower extremities so that we know that her legs can support her weight, that she'll have a normal gait, and that her feet will feel the floor. If any of those conditions are not satisfactory, do not get the mom out of bed. If she needs to pee, you give her a bedpan. But do not, under any circumstances, get a mom out of bed before her epidural is worn off. You're going to assist the patient with out of bed the first time. You ambulate with them. If you need 2 people to assist you, get 2 people to assist you. If she's really large and you're concerned, make sure you have enough help. And you're going to stay nearby when you're toileting the patient. Sometimes they'll do okay walking to the toilet, and then they stand up and their legs go out from under them. So, be very vigilant after an epidural. Some women have syncopal episodes or fainting after they deliver. It's just one of those things. They have a lot of vasomotor changes, a lot of hemodynamic changes. So even though I put it second, the first thing you're going to do is make sure that their vitals and bleeding are stable before you even try to get them out of bed. When you do get them up, start off slow, sit up first, and dangle at the bedside before standing. Make sure if they feel dizzy, sit a little longer. If they're still feeling dizzy after a couple minutes, offer a bedpan and wait. And encourage fluids and food and all of those things. And the third thing, I'm just including this, most hospitals will let you take out a smelling salt little capsule, ammonia inhalant, and that can be helpful if mom does start to feel faint. It'll kind of like jerk her back to senses. And make sure you have a wheelchair nearby if she does start to feel like she could pass out, and sit her down. It's better safe than sorry. Remember, if a patient is falling, don't try to prevent that. Just ease them to the ground gently and don't let them face plant, and then get help. Okay, so our next nursing diagnosis applies to our C-section patients, and this is risk of postoperative complications. They have the same risk of complications as anybody who's had major abdominal surgery. So we're going to worry about deep vein thrombosis. It's more common after C-section than it is after vaginal delivery. If they have risk factors like obesity or blood clotting disorders or anything like that, history of DVT, you'll probably have an order for Lovenox or heparin. If you don't have one, you should probably ask for one. And they would have to give you a compelling reason not to do it, especially you got a BMI over 30. This is helpful in preventing deep vein thrombosis. Sequential compression devices. These are those stockings that squeeze the blood. They hook up to a pump, squeeze the blood back towards the heart, prevent venous stasis. And this one is really the key to preventing a DVT. Walk, 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 walk. Walking will prevent most of the postoperative complications from a C-section. So you want to get mom out of bed as early as you can. Usually it's 8 hours after surgery. You take out the Foley and you sit her up into a chair. And then she has to walk back and forth to the bathroom and maybe around the room a little bit. And that's enough for the first day. The next day, she should really be taking the baby in the bassinet and walking the halls, at least a few times during your shift. She should really be walking to prevent DVTs and other complications. Moms can also get respiratory complications. It is an abdominal surgery, and a lot of people don't want to cough and deep breathe. And if they're laying in bed a lot, those secretions can pool. So we want to teach incentive spirometry. We want to teach them to take those big, deep breaths and cough. And if mom is in too much pain to cough and deep breathe, we're going to medicate her for pain, and we're going to teach her to splint that incision, and we're going to kind of encourage her to do it anyway. And then ambulation as soon as possible. The more mom walks, the less her diaphragm has to work against gravity, the less the secretions pool in the bottom of the lungs, and the fewer respiratory complications you'll have. Now, in terms of wound infection, we've already sort of touched on it with prevention of infection, hand hygiene before touching the incision, showering daily, letting the warm soapy water run down that incision, use a clean towel. Teach the patient to inspect the wound every day and look for things like redness, ecchymosis, edema, drainage, and approximation. If she has a foul odor, she should report it. We're also going to promote peristalsis. Paralytic ileus is uncommon, but it does happen sometimes after a C-section. We've got a bowel that's already sluggish from the lack of tone. We've manipulated the bowel maybe during surgery, and also there's narcotic analgesic, and there's bed rest. So we're going to promote peristalsis by ambulating, walk, 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 walk. If you learn nothing else, after surgery, people need to walk. We can give some medications with the physician's order or provider's order, Dulcolax, milk of magnesia, those kind of things. Sometimes Miralax or Metamucil. Now, our next actual diagnosis is pain, and we're going to deal with that with both pharmacological and non-pharmacological methods. Pharmacological methods, we have a vaginal delivery, can get ibuprofen for cramping. That's really effective because it's a prostaglandin inhibitor. We're going to try and keep up with that ibuprofen as much as we can, as long as it's not contraindicated. Moms with bleeding disorders might not be able to get it, but most other women can. And our teaching is also going to say, make sure you take it with some food or milk to prevent the stomach upset. We can supplement that with Tylenol, and Tylenol also works really well for that perineal discomfort. So we want to keep up with our ibuprofen and Tylenol. We want to avoid opioids in most vaginal deliveries unless something special happened. They had a 4th degree or a medial lateral. We're going to try and stay away from opioids, both to avoid the side effects of an opioid, sedation, constipation, nausea, and also to keep us away from excessive use of opioids that can lead to addiction and dependence. And then we have topical agents. These are also dependent on physicians' or providers' order. That's your Dermaplast spray, your numbing spray, your Tux pads, which have witch hazel in them. Sometimes you have ointments for hemorrhoids. All of those are really helpful. For sore nipples, we can give lanolin cream. It does not need to be washed off before you breastfeed. For C-section, at some point in this woman's recovery, she's probably going to get some narcotic analgesic. If she had general anesthesia, we're probably going to be giving her morphine or Dilaudid through a PCA pump. If she had a spinal with Duramorph, she might not get extra narcotics for 24 hours, but after that 24-hour mark, when the Duramorph wears off, she's going to get some Percocet or Percolone, which is oxycodone, with or without Tylenol. But we're going to want to keep her comfortable. It is major abdominal surgery, and that's when opioids are more appropriate. And then we have NSAIDs. So for the first 24 hours, when mom maybe isn't eating a lot and has an empty stomach because she was kept NPO or she was on clear liquids through labor, we usually give ketorolac or Toradol. And that is a medication that can be given through IV. And it works really well in conjunction with the spinal or even with the PCA. So the ketorolac is a really important adjunct in treatment. Now, after that first 24 hours, when mom's eating, we can give ibuprofen, and that will also be helpful. We just give it in larger doses, usually about 800 milligrams. Tylenol, very good adjunct to the narcotics and the NSAIDs. Sometimes you get a synergistic effect from using all three of these in some combination. IV Tylenol is also known as Ofirmev. It comes in a glass bottle. If your hospital uses it, it's great stuff. It really does seem to help when used in combination with other medications. We can give it PO as well, especially after that first 24 hours, 650 or 1,000 milligrams. We'll usually do it and just keep up with that. Just make sure you're under that max dose of like 4,000 grams. And pharmacy should profile it that way as well. Simethicone is also known as Milacon or Gas-X, and that prevents gas buildup. Gas buildup can be really uncomfortable for a cesarean section. You really haven't seen gas until you've seen it in a C-section patient. They almost look like they're pregnant all over again, like really like full-term pregnant. And it's so uncomfortable for them. It radiates to the shoulder, and so if we can give Milacon and get them to walk, that will help a lot. Now, for a non-pharmacological pain management, for perineal pain, that first 24 to 48 hours, we want to encourage mom to use ice packs in her underwear. Someplace you thought you'd never want something that cold. People make all kinds of MacGyver ones, or your hospital might have fancy pre-made ones that you break apart and shake or fill with ice. Whichever. Just cold, application of cold for that 24 hours is really helpful, and it reduces swelling as well. After that initial 24 to 48 hours, we use warmth. We can use a sitz bath, which is over here, and that's a tub that fills with warm water. We have a little bag that's attached to it and a little tubing that goes in there. When the water gets cold in here, release the clamp, and the water from the bag will flow in and refresh it. Also feels a little bit like a whirlpool. Some women love them, some women hate them, but it's something you can offer to your patient. And if you haven't set one up in clinical yet, ask your clinical instructor about it. They can show it to you. Peri bottles, it's that squirt bottle we use for hygiene after a delivery. You can fill those with warm water, and sometimes squirting a little bit over the perineum or over the vulvar area before mom pees will kind of prevent that urine from stinging areas that might be lacerated or places where she might have stitches. So we can use warmth there. You can use a handheld shower attachment for the same effect. Just, use a gentle spray setting. And then a warm pack to the abdomen for cramping when you've taken the ibuprofen and there's still a lot of after pains. We can use warmth to the abdomen, like a little heating pad. So for cesarean, our interventions might be a little different. You can use ice over the incision for the first 24 hours. And some women report that and the pain meds really do help. But splinting the incision is key to helping with movement, and they must move, must. If you have a woman whose culture sort of mandates strict bed rest and that passive behavior, you kind of have to override that a little bit and say, listen, normally I really wouldn't say anything, but after surgery, you're at risk for a lot of bad things happening. You need to move. Let me show you how to do that most comfortably. So you're going to splint that incision either with a buddy pillow that you make yourself or one that's on the unit, or a binder, which is like a Velcro wrap that goes around and provides support. And again, ambulation to prevent gas. Walk, 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 walk. Okay. So other sources of pain could be breastfeeding. So for a breastfeeding mother that has cracked nipples, address the latch. It's all about the latch. We can use that topical lanolin cream. It comes in a little purple tube most of the time, and it does not need to be washed off, but it helps moisturize the nipples. It helps sort of soothe them a little bit. And then we have these gel discs, and they're really, were formulated based on moist wound healing principles. Are sort of similar to a Duoderm. And not only are they comforting, especially if you put them in the fridge. If you have two sets, you put one in the fridge, and then when you change them out, you put the cold one on and rinse the other ones off and put them in the fridge. But they help heal that area, and that helps prevent infection. So they could be a really important adjunct to treatment. For non-breastfeeding mothers, we worry about engorgement, which may or may not happen in the hospital. So we're going to teach mom to wear a good supportive sports bra that kind of keeps them hugged in. You don't want their breasts loose because it creates more movement, and that's painful when your breasts are hot and swollen and hard and heavy. We're going to teach her to use cold. So ice packs, freezer, frozen vegetables, whatever she's got at home will help. Do not stimulate the breasts in any way. Put your back to the warm shower, or do not put warmth on them or try to express milk or pump milk out to be more comfortable. Ice is much more important. And then we can use cabbage leaves in the bra. And if none of these comfort measures help, they should contact their provider to see if there's something else going on. Now, next nursing diagnosis is sleep disturbance. And you might think, well, duh, she's got a baby who needs to eat every 2 to 3 hours. That's why her sleep's disturbed. Well, that's not the only reason. Sleeping in the hospital is almost always disturbed, no matter what your diagnosis is. So there are some things that we can do to protect mom's rest. The first one, be considerate of sleeping moms. You're working night shift, you're up, or you're working day shift and you're up. But mom is trying to nap or rest or sleep because the baby's asleep. So minimize noise from the nurse's station. Keep your voice low. Try to keep up with the alarms at the desk, the phone calls, all that stuff. And try and shut mom's door most of the way. Cluster your interventions. Try to get everything done in one shot. If it's night shift and you've got to do vital signs at 4 and blood draw at 5 and you catch up with your feedings at 6, try and do it all at once. Go in at that 5 o'clock hour and knock it all out in one shot. Or you can tell mom, when you wake up to feed the baby, put your light on and that's when I'll come in. Now, it doesn't get you off the hook for just hourly rounding, poking your head in and making sure everybody's okay. You still want to make sure that they're safe sleep. You want to make sure that the baby's in the crib when they're not up and feeding. You want to make sure that mom's not in any distress. So you might want to just poke in without disturbing them. But cluster your interventions, definitely. Encourage mom to sleep when the baby sleeps, and that helps when she goes home as well. Even if it's 2 o'clock in the afternoon or 11 o'clock in the morning, if that baby's napping, you go to sleep too. And that's where this next point comes in handy. Visitors are sort of an individual thing. Most people want to share the birth of their children with the people they love. But visitors are hard to control in the hospital. They really don't have a lot of control over who walks in the door and when they come. So you maybe need to educate your patient and the support person to talk to the people that might come to visit and just say, I'm really tired. Why don't you come at 6 instead of 7 or whatever? And you set your visiting hours if your hospital does not have a visiting policy. Little signs on the door that say, please do not disturb. Or some hospitals have instituted like quiet hour between, say, 3 and 4, where no one is allowed in for unnecessary interruptions. I mean, it's different if the mom calls you and needs something, but really try to minimize interruptions. Next nursing diagnosis is constipation. It's really common, and our interventions are very similar to what we would do for any patient with constipation. For vaginal delivery in particular, we want to make sure we're offering Colace. Colace is a stool softener. It is not a stimulant, so it won't make her go to the bathroom. It won't give her diarrhea, but what it will do is make that stool soft so she doesn't have to push against an area that's already sore. And that's helpful. And they may not ask for it, but you should always offer it. Ambulation, fluids, and fiber, as we said. Remember, fiber by itself without fluids can actually make the problem worse. So make sure they've got plenty of water and tell them whenever you nurse the baby, have a glass of water next to you. And remember, with constipation, people have an embarrassment factor and a fear factor of pushing. So they might withhold that stool. They might let it get harder than it needs to be. So educate your patient, offer the Colace, and you'll prevent a lot of needless suffering. So next we have readiness for enhanced breastfeeding. And I'm going to play the video, just a few points, 8 or more in 24. You may have seen that on clinical or heard reference to it. It doesn't matter if the 8 feedings are like an hour apart for 4 hours and then a 4-hour stretch. 8 or more good feedings where the baby's properly latched and actively sucking in 24 hours. And it's all about the latch. And, a video is worth an hour and a half of me talking, so I'm going to play it. And remember, we're going to revisit this topic with newborn care because it's an important part of um, newborn nutrition, so I don't have to make it too crazy.
It can take a little practice and patience, but breastfeeding is the healthiest choice for your baby and for you. Feed your baby every 1 to 3 hours or whenever hungry. Some babies may want to feed more often at certain times of the day and during growth spurts. Hunger signs include sucking on fists, fussing, or turning toward the breast. Crying is a late sign of hunger. First, find a comfortable spot to breastfeed. Use pillows for support if needed. A nursing pillow can help support your baby. Laying your baby in just a diaper on your bare chest or belly is called skin-to-skin contact. This can soothe fussy babies and make it easier for them to latch or attach onto the breast. Choose a comfortable nursing position. Just make sure that your baby's head and neck are well supported. Next, line up your baby's nose with your nipple. Support your breast with one hand and your baby's head with the other. As the baby's mouth opens wide, gently bring your baby's head to the nipple. This helps your baby get a good latch. Your areola, the dark circle of skin around the nipple, should be mostly inside your baby's mouth. Once sucking begins, you'll feel a tugging feeling. After a few minutes, your milk will start flowing. This is called letdown. You can tell if your baby is swallowing by seeing movement of the lower jaw. When babies are done on one side, they may release the nipple or stop drinking and fall asleep at the breast. If your baby doesn't release, slip a clean finger into the corner of the baby's mouth. This will break the seal. Burp your baby and switch to the other breast. Burp again at the end of the feeding. Breastfeeding shouldn't hurt. If you feel pain or discomfort for more than 20 seconds, remove your baby from the breast and try again. Always call your doctor or lactation consultant if breastfeeding is still painful. Your breasts or nipples are sore, swollen, red, cracked, or bleeding, or if your baby doesn't wake to feed, isn't satisfied after feedings, or has fewer wet or soiled diapers than your doctor recommends. Breastfeeding comes easily for many moms, but others need time to get the hang of it. Your doctor, lactation consultant, and other breastfeeding moms can offer support and advice along the way.
Okay, so just to recap, I think that visual was really important. Breastfeeding shouldn't really be excruciatingly painful. Sometimes the first few seconds will curl your toes, but after that, if the latch is correct, it'll feel like a strong tug and not an excruciatingly painful sensation. And that's what moms need to know. Again, we're going to cover this in more detail under newborn nutrition. So we'll move on to the next one, which is readiness for enhanced parenting. And this is our last slide. So we're going to promote bonding. And this is a normal process that most parents will do if you just leave them alone. But there are some things that we can do to make that more natural in the hospital just by altering our routines not to interfere with something that will happen normally. We're going to minimize separation of the infant from the mother. Sometimes it's unavoidable if they have to go to an intensive care nursery or a neonatal intensive care unit, or they have to go to the newborn nursery for circumcision or something like that. But other procedures we're going to try and do in the room, and we're going to encourage rooming in. We also encourage skin-to-skin contact, and that stimulates the tactile sense and the olfactory sense. Babies smell good and they feel good and they're curled up right into you, and that promotes bonding as well. You can promote skin-to-skin not just with the mother, but also with the support person, whoever they are, the mom's partner. Skin-to-skin contact is not a female specific or a postpartum woman specific thing. you can offer it to anybody. Just make sure that both of them are covered with a blanket. You're preserving modesty and warmth. Encourage active participation in newborn care, and that's when we talk about that teach back method. It's perfectly okay for you to change one diaper while you're showing, and then mom and dad should be changing the diapers themselves, or mom and whoever. Um, Tell mom what she's doing right as much as you're correcting whatever it is you think she's doing wrong. If uh, but give mom a lot of positive reinforcement for her efforts. Your words are powerful. They will stay with her forever, and they will make her feel like she is really a good mother. And teach normal newborn behaviors and cues. In the beginning, a lot of it is feeding cues. Um, and that's important because mom will learn to respond, and that will help her in her sense of becoming a mother. Oh, it wasn't our last slide. Look at that. We have deficient knowledge related to postpartum self care. So, the most common question people will ask you in postpartum is, how long does it take me to get my body back? Well, if you're looking to go back to what you had before you were pregnant, the answer is never. But if you're looking to just not feel like you got hit by a truck, it'll happen relatively quickly. The first week, you're going to be sore and you're going to feel really tired, and you're going to have those baby blues for the first 2 weeks. But the soreness kind of should go away by the first week, and the cramping should go away after the first week. Um, it takes about 4 to 6 weeks to feel totally normal again. That breast engorgement, usually by a week to 10 days, that's gone as the milk production normalizes and the body sort of knows what it's supposed to do, how much it's supposed to make. So they should go back to normal fairly quickly. That lochia should progress. It should take about 3 days for it to go from that bright red to that serosa. And then that lasts until about day 7 to 10, and then to alba. So you can tell mom a basic timeline and just tell her your mileage may vary, but it should always be getting more normal and never less normal. They'll have questions about sex, and we already know nothing in the vagina for 6 weeks. Return of the period, the normal period. After the lochia stops, it could be about 2 months, for women who are formula feeding. And it'll probably be, if mom is exclusively breastfeeding, it could be the first 6 months. It varies widely. It could be the whole time she's breastfeeding. When she starts offering formula and supplemental foods, she's more likely to get a period. And contraception, we covered under another video. Just remember, it's something you need to address before the mom goes home. We talked about rest and sleep. Make sure the mom knows how important it is to sleep. She may have other children at home, but she should not try to be the hero. Enlist the support of whoever will help you. Make sure they're the ones helping with the housework and the other kids, and she's taking care of herself and her baby. Women frequently want to know about exercise and diet. Um, Kegels are the exercise we usually reinforce to promote pelvic floor tone. Remember, everything loses tone those first couple weeks. So Kegels, it's that PC muscle, the pubococcygeal muscle, that can stop and start the flow of urine. So you teach mom, that muscle, if you were to stop the flow of urine in the midstream and then start again, you're going to squeeze that muscle several times a day. And that's going to help you get your pelvic floor back. In terms of other types of exercises, walking is usually okay within reason, not speed walking on the treadmill for 45 minutes necessarily, but walks around the block in the stroller. Usually okay. Other types, more vigorous types of exercise, should really wait till that 6-week postpartum checkup. Weight loss. Most women think that they're going to lose all the weight when they lose the baby. Baby weighs maybe tops 9 pounds. You're going to lose some from the fluid. You're going to lose some from the placenta. But there was always extra there to, promote nutritional stores. The body wants to put a little bit of body fat on. It could take about 6 months to take that off. If they are formula feeding, they should cut back 300 calories from their pregnancy diet, but make sure that the foods they are eating are of high quality nutrition. And then if they are breastfeeding, they will burn at least 500 extra calories a day when their milk comes in. So they may not have to change their diet at all, and they will still lose a pound a week. Mom should be encouraged to continue that prenatal vitamin at least until her 6-week check. Some providers will encourage her to keep it going a little bit longer, depending on what her iron stores were. We also want to teach mom warning signs of all the things that can happen postpartum. I'm going to give you a handout or a link to a handout in Canvas. And then we're going to talk about it more when we talk about postpartum at risk. But there are some things moms should know what's normal and what's not. That severe frontal headache, pain in the legs that could indicate a DVT, bleeding that soaks more than a pad an hour, a clot bigger than an egg, any trouble breathing, any chest pain. Those things are warning signs. They rarely happen, but when they do, they're an emergency and she should know to seek help immediately. And then we refer to additional resources. Um, Mom needs some place to go when you're not there. So handouts, referrals to websites, referrals to community support groups, all important. And now we really are done, I promise. And I will see you in class.